Okay, now let's talk about the management of pre-existing drug therapies. Okay, so we will cover all the drugs that have to be stopped before giving any anesthesia to the patient or before giving any or before doing the surgery, right? So let's talk about if the patient is on MAO inhibitors, right? So if the patient is taking modern MAO inhibitors like selagelin, then they can be continued. They can also be given in the morning as well, right? But if the patient is on, older MAO inhibitors, then we have to stop them 3 weeks before the surgery. Okay. Uh, what it can do is it can react with pethidine. Okay. So it can cause severe sympathetic reactions with pethidine. So that is also important. Second drug that we have to stop is, okay, do we have to stop anticonvulsants? No, we don't. Okay, so if a patient is taking anticonvulsants, we have to continue the drugs. Okay. Now, if the patient is taking levodopa, they have to be continued as well. Now, coming on to oral hypoglycemia. Now, as we know that uh, mostly the patient is NPO at the time of surgery, so the patient is already hypoglycemic, right? If you give oral hypoglycemics to the patient, he can land into the hypoglycemic shock. Okay, so in case of minor surgeries, that means the surgery is lasting for less than 30 minutes. We have to give. We have to omit the morning dose. Okay, otherwise the patient can land into hypoglycemic shock. In case of major surgery, that means lasting for more than 30 minutes. If the patient is taking oral hypoglycemic agents, we have to shift OHA to insulin. Then we have to switch to insulin, and the morning dose of insulin has to be omitted. That means we don't have to give the morning dose, obviously, because we want to avoid hypoglycemia. Okay, now coming on to oral anticoagulants. Now, for example, if a person is on warfarin, right, any oral anticoagulant, we have to stop it 3 to 5 days prior to the surgery. Now, we have to start the patient on low molecular weight heparin and last doses given up to 14 hours prior to surgery. So, for example, if the surgery is on 10 in the morning the next day, we have to take the last dose of LMWH uh, at around 8 p.m. the last night. Okay, so we have to stop the drug 14 hours prior to surgery when the anticoagulation is needed. Right. If the patient is on regular heparin, then we can give it 6 hours prior to surgery. Okay, so for example, if the surgery is on 10 a.m., the person can take his last dose of regular heparin at around 4 in the morning. Right. So this is how it works. Now coming on to OCPs. So basically, when a person comes to you, we're talking about oral contraceptives containing only estrogen, right? Or containing estrogen also. I mean, like in combination of it or either alone, we have to stop it 4 weeks prior to the surgery because it can lead to thromboembolism, right? Pop pills can be taken, right? Pills containing only progesterone can be continued. Now, coming on to antihypertensives. So, we have to stop ACE inhibitors and ARBs, okay, because they can cause refractory hypertension during anesthesia, right? So refractory hypertension can be caused due to ACE inhibitors and ARBs. Okay, other agents can be continued. Now, anti-anginals, nitrates, they can be continued, but if the person is taking aspirin, we'll discuss that later. So we've got a criteria for that as well. That we'll talk about in the next page, I guess. Now, lithium. Lithium should be stopped 2 days prior to surgery. It prolongs duration of action of the NMDRs. So that is really important, right? So it prolongs the duration of action of NMDR, so it has to be stopped 2 days prior to surgery. Now, steroids, the duration of therapy more than 1 week in the last 1 year. In these cases, morning dose must be given. Okay, in these cases, morning dose should be given. If a person comes to you and says, डॉक्टर साहब हम तो खाते हैं आयुर्वेदिक दवाइयाँ, अब आयुर्वेदिक दवाइयाँ रोकनी है या नहीं? Now see, basically nobody ever tells you about the Ayurvedic medicine they're taking. Okay, they won't come to you and say that they won't come to an allopathic doctor and tell you about the Ayurvedic medicine. But again, you have to inquire. You have to ask them if they're taking the Ayurvedic medicine, right? In those cases, if he says yes, tell him that we have to delay the surgery. Like, we'll do the surgery after 2 months, and you have to stop taking the medicines. Instead, take some allopathic medicine instead, which are not contraindicated in the during the surgeries, right? So herbal medicines should be stopped 6 to 8 weeks before the surgery, right? Smoking, okay, smoking is pretty important, and we've got tons of smokers in our country now. So we have to ask about the smoking habit, and it has to be stopped 6 to 8 weeks before surgery. Why? That is the question. It inhibits the ciliary movement, right? It inhibits the ciliary movement. So if the smoking is stopped like 12 to 24 hours prior to surgery, so if you don't tell about the risks of smoking before surgery, what he might do is that, you know just to be precautious, people try to be over smart most of the times. What they do is they stop smoking like a day before. What happens is that there'll be fall in the carboxyhemoglobin level, and that level, this fall in the carboxyhemoglobin levels, will lead to the shift in the HbO2 dissociation, and that will shift to right. Okay, so this is very dangerous if you stop smoking like a day prior to surgery, right? Also, it causes sympathetic stimulation. Now, this sympathetic stimulation, it causes sympathetic stimulation, surfactant, and increased requirement of the amino steroid, right? Muscle relaxations. So when there will be decrease in surfactant, so whatever muscle relaxation relaxants we give, there will be increased requirement of those, because the level of surfactant is already low, so we have to give more of the MRs in these cases, right? So there will be increased requirement of the amino steroid muscle relaxants. Now, what about ATD drugs? They should be continued. Very important. Okay. Okay, what about antiplatelet drugs? Now, as I told you, that aspirin will be discussed later. Now we're discussing it. Aspirin, if the dose is less than 75 mg, less than equal to 75 mg, it can be continued for all the surgery except closed space surgeries. So we have to continue it. Exceptions being brain and the spinal cord surgery. Now, we have, if the dose of the aspirin is more than 75 milligrams, then it has to be stopped 3 days prior to surgery. Okay. One important drug is clopidogrel, right? Clopidogrel, as you know, that we use it in post-MI. So clopidogrel, potent antiplatelet, right? Stopped 5 to 7 days before surgery. Okay. Ticlopidin has to be stopped at least 2 weeks prior to surgery. Now, there's a syndrome called as the Mendel's syndrome. That means aspiration in pregnancy. Okay. So the criteria is that the pH of aspirate is less than 2.5 is less than 2.5, and the volume of aspirate is more than 25 ml. So that is the Mendel's syndrome. So aspiration in pregnancy. Okay. If the pH is less than 2.5 and the volume of aspirate is more than 25 ml, right? Now, what is the NPO duration? In case of adults, the solids, NPO. Okay, so when the patient comes NPO to you, what do we actually tell him? So the patient should at least be 6 hours clear of the solid food. Okay, so the patient should not take any solid food 6 hours prior to surgery. That is NPO. Clear liquids, 4 hours. Okay, so he cannot take clear liquids 4 hours prior to surgery. In case of infants, 4 hours for the solid food. Okay, milk included in solid. That is for infants. And clear liquids, it's 2 hours. So this is also very important. Okay, so we'll talk about the pre-medication in the next video. Thank you.